morning, everyone. Good morning, Samantha. Good to see you here. Thanks for joining us for our third and final community forum to discuss the alternative payment model for primary care, the APM1 program. My name is Nina Bastian. I'll be facilitating our conversation today, along with my colleagues Ashley Brown and Kimberly Fu at the Colorado Health Institute. We are also joined from the Department of Healthcare Policy and Financing, who will be speaking to you today. We have Zoe Martian-Pincus, Nicole Nyberg, and Dr. Peter Walsh. As as a reminder of our agenda this morning, we'll spend a few minutes going over housekeeping and our goals of the APM and of this session. We want to spend a little time recapping all of the changes from forums 1 and 2. So if you haven't been with us yet for one of these community forums, not to worry, we will catch you up this morning on all of the discussion points and decisions that have been made to move forward the program for next year. And then we'll spend the bulk of the time talking about some changes to a few programmatic items. Since our last forum, the department has gone back, taken your feedback, and made some new proposals. So they'd like to share with you the plan, not only for next year, but also for the next 3 years. And then, as always, we'll save 15 minutes for public comment at the end. This morning, we ask that you use the Zoom Q&A function to ask any questions related to the discussion topics. So you'll notice we're not using Menti today. So sorry for those who love Menti. We actually only have, one discussion question for you today, and we'll just do that right in Zoom. So everything will be in Zoom this morning. We ask that you use the Zoom chat box for comments or technical issues, but not for questions. The chat will not be monitored for questions. We ask you to use the Q&A because it documents all of the questions really easily along with the answers so that all participants can track what's being asked. Also, as a reminder, today's meeting will be recorded and posted to the APM website. And as always, after this meeting, the Colorado Health Institute team will continue to accept additional feedback on today's discussion at focus groups at coloradohealthinstitute.org. We do take all of that feedback and compile it to share with the department, and we'll also be developing a summary memo to share with the department, in November. That includes all of the feedback that we have received, summarized around the different discussion topics since we started these communications or these discussions back in August. So thanks to all those who have reached out to us so far at focus groups at coloradohealthinstitute.org. Please continue to do so. And now I'd like to pass to Dr. Peter Walsh, the Chief Medical Officer for the department, to kick us off.
Good morning, and again, thank you very much for participating in this session. We very much appreciate the feedback and dialogue that's accomplished here, and we do read, first of all, we listen to you during these meetings, and as well as we do look very closely at the summaries of feedback, as well as the letters that follow these sessions, so thank you very much. Our mission, which we've talked about a number of times in the past, of course, is to improve healthcare equity, access, and outcomes for the people we serve while saving Coloradans money. We also are trying to drive value in the process of doing that. And next slide, please. And as a result, our goals for this APM1 program are as depicted on this slide. We do want to provide long-term sustainable investments into primary care. We do want to reward performance and introduce accountability for outcomes and access to care. And we want to grant flexibility as well. And finally, we do also, and this is important to us, align with other payment reforms across the delivery system. So as a result of wanting to align with other, I'll say, payment reforms that are occurring, that's one of the reasons why changes do occur in this program, and we are trying to continually enhance it. And as changes occur, we will consider them and try to make sure we have alignment where possible. And regarding rewarding performance and reduce accountability, I'll speak to this at the end, but ultimately, while not accomplishable in the near term, we want this program to hinge off of, I'll say, value and performance for Medicaid members, and to the extent possible. Nina, I'll hand it back to you.
All right, thank you. So to just mention again, what we'll be talking about in today's meeting, we'll be recapping program updates from the August and September community forums to get everyone up to speed on what was discussed and what changes will be made moving forward for the program. And then we'd like to review the department's vision for 2023 and beyond. As I mentioned, the department took your feedback, made some changes to some of the proposals that you saw in our September meeting, and is bringing forward a new proposal for 2023 that they'd like to share with you. This is our third and final forum, so you won't see anything under covered in future forums here. And as always, what is not covered in these discussions is any conversation around program eligibility, attribution, or specific benefits. So let's dive into the recap, and I will pass to Zoe.
Thanks, Nina. Welcome everyone, and thank you for joining us for our last community forum. So I know we covered some of this in the last meeting, but we had a few follow-up questions. So just want to clarify this again, the eligibility for participation. So participation in the APM will remain at 500 attributed Medicaid enrollees. If providers want to opt in, they must email the department and or their RAE expressing their interest in participating along with a good reason. So the department and the RAE will review the PCMP's data in the data analytics portal and any ECQM data that they have to see if participating is appropriate, to make sure that they have a big enough denominator for these measures to excel when it comes to reporting. So if we decide yes or no, the department will follow up with the provider with our decision. So an example of a practice that opted in last year, I believe there was only one. They had just received a new Medicaid ID, and so their attribution just really hadn't carried over to reflect that. So they really did have the member attribution to support their participation. And, you know, on the reverse, a provider opting out might be in a similar situation, or maybe they're new to the APM, newly contracted in the ACC. And so they have the attribution, but haven't been in the program or in Medicaid long enough to have data to support them participating. Next slide, please. So we've circled on this, I think, a few times now, but just wanted to recap really quick. We had an issue with the reporting of both well-child visit measures in our data analytics portal. And so for 2021 and 2022, we will be awarding full points for these measures. However, they are being fixed, and so we should be able to accurately calculate them for program year 2023. And the 2022 baseline data will be available corrected in April of 2023. So we also wanted to circle back on the depression screen measure, which we talked about last time. The department received numerous questions on the new depression screen and follow-up measure. There was also a lot of concern about the short turnaround from when we hear from CMS about the adoption of the measure and the time to implementation. So if this measure is adopted by CMS, then the department will follow that decision. We are working with our data section to get baseline data to show providers so they have a better sense of their baseline prior to the start of the program year. The data most likely will just be the most recent 12 months. So it won't necessarily be calendar year 2021 and not necessarily calendar year 2022. So kind of a combo since 2022 is still in progress. But if this measure is adopted, it will be available in the data analytics portal or the DAP, which is not true currently. The administrative version that we have for the depression screen measure. And if you chose it as an ECQM, it's obviously also not in the data analytics portal. We will know by mid-December of CMS's decision, and we will let you all know as soon as we possibly can. Next slide. So we know that a lot of the concern around this measure was what counts as follow-up for a positive screen within 30 days. So we really just wanted to highlight some of the things that do count as follow-up for the measure, such as an outpatient, a telephone, e-visit, or virtual check-in with a PCP, so primary care, or it could be behavioral health. Dispensed antidepressant medication also counts for this, as well as if they're screen positive on a PHQ, and then they do a longer, more in-depth screening with a PHQ-9 that shows as negative, that also counts as follow-up. So we really just want to put providers at ease that a lot of these things can be done in primary care and do not necessarily have to be outsourced to behavioral health, because we do know there are limited resources, and 30 days is a pretty tight turnaround for that. So I'm going to pause here and see if there are any questions or comments on this measure.
Thanks, Zoe. So we invite you to raise your hand if you'd like to speak to us. We'll also be taking some questions in the Q&A. So we have a couple participants who have raised their hand. And Kimberly or Ashley, who do we have up first?
We're gonna go with Jill first.
Good morning. So a couple things. One is the CMS measure for this has very specific follow-up requirements, many of which are not these. And I guess my question for you guys is, how do we code it in such a way that you then pick up that we've had the follow-up? So if you're just picking it up via the ECQM measure, the way CMS sets it up, then, it's no problem. But if you're wanting like an additional G code or something, then that becomes a little more difficult.
Sure. Yeah, thank you. And Nicole or Dr. Welsh, does one of you want to take this?
If Nicole's on, I'll yield to her, but if she's not, I will speak to it.
I'm on. I can jump in first. Pete. So Joe, the current CMS core measure has different follow-up requirements than what's on the screen. But CMS is looking at changing to a depression screening and follow-up measure that requires a follow-up visit or follow-up care of some kind. And the current one looks just like a follow-up plan is documented in the chart. If the measure is adopted, we will get specifications out to everybody so that you guys have the correct coding information that you need. Did I touch both parts of your question? Did I miss anything?
Yes. And so basically the way that it gets collected via the EMR is our vendor, builds out the measure. We click the appropriate boxes and then it just collects it. So I am happy to hear that you'll be able to accept that that level of reporting, because I know that with we're doing this with Colorado Access, and at the moment they can see how many people have had a depression screen, but they can't get the how many people have a follow-up plan, right? And so there's been some discussion about adding some additional coding, and I'm like, oh, that just makes life hard for us. So I'm glad to hear that. Yeah, and hopefully our vendor will update the measure per CMS, and it will be no problem. Thank you.
Yeah, so this measure actually doesn't look at a plan at all. So we wouldn't be looking at G codes to capture that for this one.
Great.
But this code will be looking for whether a screen was accomplished, and there's a methodology in it that does require coding in the sense of what there's specific codes for what specific tool was used, the score, which then drives the logic on whether or not follow-up is required. So I think that it's clearly necessary, because this is a change, obviously, that requires everybody coming familiar with the measure. So when CMS makes their decision, they will also issue a measure specification, and then obviously we need to have a discussion around that. But I do think coding will be an important element of it, in that it needs to know that the visits occurred. It needs to know what other types of visits occurred. In some cases, it'll match with the pharmacy claims in terms of dispensing medications. And so as opposed to you using a G code to say, when you had a positive screen under the current measure, whether, what your follow-up plan is using a G code, it won't presume that it won't end there. It'll look for what really happened. So it'll look for other E&M codes that follow it based on the measure specification. So there is a coding element of it. I don't want to mislead anyone. This is different than the current measure.
Thank you.
Thanks. All right, we've got a few more hands raised. If we want to go to Barbara Bishop.
Thank you, Nina. I put a Q&A, a question in the Q&A, and I wanted to really quickly oh, I see Nicole answered that, so we'll pass that one. It was just in regards to the rolling data piece for depression screening. I just asked if it was for this year, because I know that Zoe had mentioned something about a rolling data or the last 12 months for depression screening. So I just wanted to clarify that. And the second piece is in regards to eligibility, if PCMPs are either less or more than the 500 and they would like to or participate or opt out, they need to contact the RAE first, and then the RAE contacts the state. Is that correct?
I can take that, Barb.
Yeah.
So you guys, the RAEs are kind of like, I feel like you kind of are gatekeepers, if you will. So your PCMPs most likely go to you before they come to the state. They're welcome to come directly to me, but they tend to go to the RAEs first, and then the RAEs come to us. But they are welcome to come directly to us if they wish. As for the rolling data piece, yeah, we're just trying to get some baseline data out to practices, so they can kind of have a sense of what their numbers look like with this new measure. It will normally be a calendar year as the baseline. This is just kind of a different situation where we don't have a 2022 calendar year yet, but 2021 might be a little, it's almost 2 years ago, it feels like. So a kind of combo of just the most recent 12 months to give providers an idea of what their numbers look like.
All right, that makes sense. Thank you.
All right, we can go to Sarah Gallo next.
Do you hear me?
Yes, we can.
Okay. So I help run a telemedicine company that focuses on Medicaid patients for the state. And what we're trying to do is try to work with some of the practices to help with them meeting this measure, since we do see a lot of co-diagnoses. Does the follow-up need to come from the PCP or a behavioral health provider that is like under one of the behavioral health managed care plans, or can it be once we like send a follow-up summary, will that count towards their follow-up since we are on Medicaid?
Great question. And
This is
Dr. Wall?
Nicole. Can you hear me?
we can hear you, Nicole. Yeah?
Okay. So I'm not sure I'm following exactly what you mean. If you send a summary, that wouldn't count. It would have to come through billing.
So yeah, it would be a claim still. Obviously we're a multi-specialty practice, but mainly kind of do like a bridge to local care, like primary model. And so what we were told is if we're not identified as one of these two, like the PCP with an attribution or behavioral health provider, we may not help that primary care provider with this measure, even though we did follow up with them and, cut, since they don't have necessarily the availability that they need to be able to do that.
Sarah, would you be able to send a follow-up email and we can look at the provider type against the spec that we currently have? And
Yeah, sure.
just kind of look into that. I don't know how common that's going to be, but I think that we should probably take that offline to figure that out.
Yeah, Ray 4 has specifically asked us about that with their care coordination. So thank you.
Thanks, Sarah. Okay, we've got 2 more hands raised and then 1 or 2 questions remaining in the Q&A. If we want to go with Erica Pike, you can unmute
Thank
your
you.
line. Yeah.
Thank you. Erica Pike here with the Colorado Academy of Family Physicians. Can you just remind me, is this going to be a required measure or is this going to be one of the optional measures that PCMPs can choose from? Thank you.
Yeah.
Hi, Erica. This will be a mandatory measure. It's going to replace the current mandatory measure we have for depression screen and follow-up. We will obviously be monitoring the data from this measure very closely over the next year to ensure it's capturing correctly in the way we want it to. So our goal is to still tie points to it. But if it's not working for whatever reason, we always have the option to reevaluate at the end of the year or towards the end of the year and let practices know.
We have 1 outstanding question in the Q&A about a same-day behavioral health visit to address depression, checking to see if that would count for the measure.
I was trying to answer other questions and pull up the spec, so I just need a minute and then I will respond to it.
Sure. Okay. So Stephanie, keep an eye out for an answer for that coming in the Q&A. And I think we've got, oh, Dr. Welsh, yeah, go for it.
Yeah, I think ultimately we need to know for sure what the measure specification that comes out of CMS, because it could in fact be different than the current DSF. We don't think it will be, but we don't know what the outcome will be here. But currently the actual verbiage is on or within 30 days. Okay, and so the answer is if nothing were to change, yes, it would, but we won't know the final answer until we get the measure specification. And Nicole, that's at least my understanding of the measure.
Yeah, that sounds right. I just thought that I would pull up the spec that I have to clarify.
All right. I think we've answered all of our attendee, we've gotten to all of our raised hands. Team CHI, is there anything left in the Q&A that we need to address? I'm going to keep us moving just for the sake of time. Please continue to put any questions into the Q&A in Zoom, and we will pause again in a few moments to take some more questions. So Zoe, I'm going to pass it back to you.
Sounds good. So we just want to circle back quickly on the adult immunization measure that we talked about last time. So this measure will be included in the APM set. If it is adopted by CMS, it will not be included if not adopted. And it will be an optional measure. So it's not mandatory by any means, but we did hear some concern about, like, if you receive an immunization like at Walgreens, does it count for the PCMP? So this information will be available through the Colorado Immunization Information System data feed, which feeds into the data analytics portal. So it should still be tied to the PCMP based on a member's attribution. Next slide. And here again are just some of the details about the immunization itself. It is a 4-part measure. If a PCMP doesn't provide some of these immunizations, then it would be reduced to like a 2-part or a 3-part measure, and then averaged out. So you're not held responsible for immunizations that you don't necessarily provide.
All right. Why don't we pause here for any additional questions about the immunization measure or anything else on your mind so far? We do have one outstanding question in the Q&A around having a pilot year for the depression measure before awarding points to see how it does versus after the fact. Curious if, excuse me, Zoe, Dr. Walsh, Nicole, if you all had thought of that, if that was something that made sense, or kind of what your reasoning was for moving forward.
I can jump in first. So the reasoning for pushing this in this way was to be in compliance with some federal required reporting for the state. In the CMS core measure set, the depression screening is going to be a mandatory measure for us to report, and we wanted to get this program aligned with that as quickly as we could. I don't know if Pete, you wanted to add anything to that?
I agree with what Nicole just said, but the other, so we're trying to get, one of the things we hear as a department is, the short version is we're going to consider all the timing on this based on when CMS rolls out, both makes their final decision as well as when they issue measure specifications. So we'll consider, what is actually executable based on that timing. And on the other hand, we get feedback really sort of both ways on these types of issues, where one argument is we want the changing to continue, the continuous changing to settle down, and this constant change is challenging for practices and for, I'll just say, all providers when we make changes to metrics. So we're carefully trying to weigh that, but the flip side of it is we know where we want to go as a department, and that is we want to focus on, for the most part, the mandatory core measures that we're required to report to Medicare or Medicaid. And we're also trying to align our measures with our health equity plan, which include a subset of those. And I think I've mentioned other setting earlier, we're trying to consider carefully alignment with other programs as they evolve in the state. And so the question is how quickly we can get there, but and we're trying to weigh to the extent to which we pull off the Band-Aid and make these changes by the rate at which we delay them. And so We're going to have to report on these if CMS makes the changes, but we are going to consider whether it's executable based on when CMS issues, particularly the measure specification. So we will have to make that decision. There's a whole bunch of contingencies here based on what CMS does and the timing.
Thank you. And we have one hand raised. Stephanie, we can go ahead and hear from you.
Hi, this is Stephanie Sandu. I'm co-interim chief healthcare officer at Stride Community Health Center. And I just wanted to reiterate the request to not tie it to points. It takes us a full year just to understand and measure, design our workflows, make sure we're reporting accurately. And we're on board with aligning with the health equity plan and aligning with CMS, but it's really hard to do that while at the same time trying to improve performance. And I appreciate that you guys are trying to be responsive to the request for no change, but we also need to be responsive to the request for alignment. And the reality is I'm getting evaluated for depression screening 4 different ways with this change, right? I have the depression screening through UDS as an FQHC, including a remission measure. I have the G codes that I need to be submitting through the APM for the RAISE. And now we're hearing this is a 4th iteration of how depression screening is going to be captured. So it's just really challenging to unify one workflow to meet all of those data requirements. And it would be really appreciated if we had that break and pause to just have visibility to our data, visibility to the specs before we are potentially going to be penalized for not performing on it.
Thank you, Stephanie, for sharing. All right, I'm going to keep us moving to the next section of the agenda. Please continue to put your questions in the Q&A, and we will pause again momentarily to accept more comments and questions. So thank you everyone for your feedback so far. And Zoe, I will pass it back to you.
Thank you. So we're going to be switching gears a little bit and talking about some new ideas. So we heard from all of you at our last forum and in follow-up letters, there was a lot of concern about removing structural measures and reducing the overall number of measures. So the quality team came together after the last meeting, and we really rethought our approach on how we want to phase out our structural measures. Getting rid of them all at once seemed a bit drastic and was not also received very well by our stakeholders. So over the next few slides, I want to walk you through our vision for program year 2023 and beyond. We know the changes we make year over year can be really administratively burdensome, but we do believe that in the next few years, we truly can get to a place where we don't need to make so many changes. COVID really threw off the timeline considerably, but we still want to have a phased out approach of our structural measures. And we're going to kind of lay that out for you. So nothing is set in stone. We will continue to hold these forums, and we hope that by sharing this vision with you over the next few years, that'll help all of you to prepare and kind of know what is coming down the pipeline and not maybe feel so blindsided at the end of the year. So with that, we're going to walk you through 2023. So we came back to the table, like I said, after the last forum, and here is kind of what we came up with as hopefully a middle ground for program year 23. We would still like to reduce the overall number of measures selected from 10 to 8 for non-FQHC providers. We will be keeping the 3 mandatory measures, and then a provider must then select an additional 5 measures with a structural measure cap of 3 measures. So that means that a PCMP must select an additional 2 clinical quality measures, and then they are still allowed 3 structural measures. FQHCs and PCMH recognized PCMPs will still report on 6 measures. That's not changing, with 3 of them being mandatory, and then the other 3 being clinical quality measures. So This is a slight change for PCMH recognized practices who are not FQs, because they previously were still allowed to choose from a very small subset of structural measures. And we are going to be working through the math, so I'm sure you're all eager to see that. So let's hold any questions on the math piece and how this all adds up for just another moment. Next slide. So in addition, with reducing the overall number of measures, we are proposing a slight change to the measure points themselves. So we're proposing that all mandatory measures will be worth 40 points. And then all the remaining clinical measures will be worth 35 points. And then all structural measures will be worth 20 points for a max of 60 points total that can be earned from structural measures. We still want to keep the PCMH credit recognition, so we will be keeping that. However, we are going to be reducing it from 100 points to 80 points to be a little bit more aligned with the structural measures that other practices select, but we still want to recognize that this certification or accreditation is more involved than just applying the structural measures. So we still want to award more points for it than just choosing structural measures alone. So after this slide, I promise we'll get to some of the math, but we just kind of want to lay out like a side-by-side comparison to show the program requirements that we currently have versus our proposal for next year. So this is pretty much the same as what I just walked through, but just more of a side-by-side comparison. We will be keeping the total points needed to achieve a rate change at 200. And I'm going to pause here for some questions, but before we get to the math, so if you have a math related question, maybe save it for another moment or two, but I do want to just kind of pause and see if anyone has questions on this so far.
Thanks, Zoe. It doesn't look like we're getting any questions yet in the Q&A or from participants. We have one question in the Q&A about why are we still at 8 measures? Katrina, if you would like to provide a excuse me, a little more detail around your question. Were you hoping to be at 10 or were you hoping to be at 6? Appreciate your clarification there, and we'll be sure to answer your question. And Zoe, maybe let's keep moving to the next couple slides that might generate some more questions.
Let's stay, there was a request to just stay on this slide like another moment.
Oh, sure.
Because there's a lot of info. This will be recorded and posted. The slide deck was also sent out and is on our website. So
yeah,
actually pause for a moment.
If I could ask Team CHI to put the link to the slides in the chat, and folks can have that handy there. So you'll be able to look up this slide is slide 20 while we keep going.
So there was a question about for FQHCs. FQHCs are still going to be at 200 points. So you'll need to earn 120 points from the clinical measures. And then I think almost all FQHCs are also PCMH. So they'll get 80 points from that. So it's not a terribly big change for FQs because you already didn't select structural measures. So really you just have to score an additional 20 points from the clinical measures. As opposed to 100, it'll be 120.
All right, Zoe, let's go to the math slides and then we'll come back for any additional questions from the group.
Sounds good. So here's the first of 3 examples on how PCMPs can earn 200 points with 8 measures. So as you can see in this example, we have the 3 mandatory measures, 4 additional clinical measures, and 1 structural measure. So in this case, this PCMP earned full credit for 1 of their mandatory measures, 2 of their additional clinical measures, and then full points for their structural measure. And then they earned pretty close to full points for 2 of their other clinical measures. They did earn 0 points for 2 of their measures. But as you can see, they still were able to achieve that 200 points. Let's go to the next example. In this example, they also had, the 3 mandatory, they had 2 additional clinical measures and 3 structural measures. They were able to achieve full points on their 3 structural, full points on 1 of their mandatory, and full points on an additional clinical measure. And then they were only able to close the gap between 50 and 66% for their other measures. So they earned partial points there. And so they were still able to achieve their 200 points. And then our last example, you're able to see that still 3 mandatory, 2 additional clinical measures, and 3 structural measures. So I guess an important thing to point out here, and this will be a big change, I think, for our pediatricians and pediatric practices, is that we are going to allow practices to choose both well visit measures or both immunization measures. So last year, you only chose 1 immunization measure and 1 well visit measure in your mandatory set. And then you had to come up with the rest of your measures from the rest of the list. So we are making that change in that you can select 1 well visit measure in the mandatory and then the other well visit measure for the rest in your other subset of measures, as well as for your immunization measure. However, when those measures are chosen outside of the mandatory set, they will be worth 35 points instead of 40. We know this doesn't totally fix the lack of measures available for pediatric practices, but we're hoping this helps a little bit and allows you to focus on both well visit measures if you're able to do so, and more than 1 immunization measure if you are able to do so. So in this example, the PCMP earned partial points on all of their clinical measures and then earned full points on their 3 structural measures, and they were still able to achieve 200 points. So I am going to stop here because I am sure there are questions and comments and all of that.
You bet. All right, so we do have a couple folks with their hands raised. Let's start there. Elizabeth, if you want to go ahead and share with us your question.
Yes, hi, thanks so much. This is Elizabeth from Children's Hospital. I use she, her pronouns. And first of all, just thank you once more for these comprehensive and detailed stakeholder sessions on the current APM program. It's been really fantastic to have this kind of access directly to the clinical folks at the department and to CHI as well on our attempts to keep up with this program. So I hear that you have heard, HCPF, our requests to take a longer time to implement changes. And so I really appreciate that you're hearing that message and that you're working to give us more data quicker to be able to prep ahead of time, especially in this kind of unknown period about CMS changing the core set. But I guess just to add to that and to really reiterate a point that perhaps other people have made, that the measures changing is disruptive in all the ways that people have already expressed today and previously about taking at least a year to implement all the new systems to accommodate that. But Also, the points page. So I had sent in the chat, asked a question about just pausing on the points page to process all those changes, because the points when the points change, it is just as disruptive because the points are tied to payment. And so reconfiguring all of the financials, both current financials and projected financials around a new point system, that also takes a bit of work, like a lot of work. And so even if we kept the same, even if CMS kind of locked down the core set for 3 years, for example, which would be nice, the points changing every year is also a big lift on PCPs. So I do appreciate the efforts you all are making to give us more time and give us more data faster, and to consider ways to accommodate the long processes that PCPs need to make these adjustments. And so the chat conversation about maybe not tying it to points, maybe not tying new measures to points for a while, but then also just to note that changing the points models is an additional level of complexity for practices to adjust to. Thanks.
Thanks, Elizabeth, for sharing your feedback. And Jill, if you want to go ahead with your question or comment.
I think it's less of a question, it's more of a comment, and that is, you know, we're a pediatric practice, and there just aren't that many options. And it feels like it's not our fault that CMS doesn't have more measures that are applicable to pediatric practices. And by, you know, you keep narrowing like structural measures, and if I heard it correctly, if we choose to break out each of the immunization measures, then we don't get 45 points per measure, we get 35 points per measure. And again, it feels like you're penalizing us for being a pediatric practice for things that like really aren't within our control. And you know, and I guess what I would say is, you know, the pediatric practices do a great service, and why make it harder for us to earn full points by, you know, by making it difficult? And it's not that we don't want to participate. It's not that we don't want to do good work. We want to do all that. And it's just making it more difficult as you continue to narrow the, you know, the possibilities, and then give us fewer points for the things we can choose. And so I guess that's my comment. And my question is, you know, how do we get to a place where it's a little more of a level playing field and pediatric practices can, you know, have the ability to earn full points without, you know, really having to do something extraordinary?
Thanks, Jill, for sharing. And I know we've gotten a lot of feedback over the last few weeks about making sure that pediatric practices are able to succeed in this program. And I think that the way that the department has devised this point structure does even it out. But I'd love for Zoe or Dr. Walsh, for one of you to chime in and share your thoughts.
Yeah, I can chime in, and if Dr. Walsh wants to, he can. So if we look at the overall list of measures that we've chosen for the APM, it actually is pretty comparable between the adult and pediatric practices, especially if we allow pediatric practices to choose more than one of the well visit and immunization measures. We do understand all of the measures, like there are those two follow-up, you know, measures that we talked about last time or the time before, that a lot of people just can't report on. There are more pediatric measures in the CMS core measure set. We just don't have the data to report on them, which is why they're not part of the APM list. So there are lots more core measures for adults and pediatrics. They're just not, there's not enough data there. I'll yield to Dr. Walsh.
Yeah, I was gonna actually, I had one question and then one observation, but I'll go with the observation first. Part of that, Zoe is correct. There's actually, I think, when you add it up, depending on how you view applicability to a primary care practice in terms of what measures they can actually control, you could argue that there's 12 or 13 on the at least the 22 core measure set that could be applicable to primary care. The challenge we have is with accurate data, and there are multiple reasons for being able to accurately measure that. And so we'll keep what you said in mind very much so. I guess I do have one question for you is what number for you would be enough? Because, as I've joined the department 2 years ago, I think you can tell the direction we're trying to do. We're trying to go into the core measure direction. We're trying to find the balance between too much change and getting to the end point. I will say that the way the core measure set typically operates on a yearly basis is between adult children, of which a subset are behavioral health in both of those sets. There's roughly in the mid 50 number of measures. They go up or down 2 or 3 a year. So there's 1 to 4 new ones a year. There's a few that go away. And so it's not, I'll say 92, 93% stay the same year to year. This year, we're trying to get ahead of it and what we know are potential changes. So I am curious what you think would be enough for pediatrics, because we could push much harder, but frankly, it'll require some coding change behavior for the administrative measures on the part of providers, which will not be an uneffortless process for providers to look to basically enhance their coding, because they will not be all ECQMs. And then we, of course, have to make sure that our pipelines are working correctly. So I'm curious, from your perspective, what's enough?
Yeah, I was thinking, sorry.
Thank you.
So let me think on that. And then I will send an email to the focus group thing.
Oh, we're very interested in your thoughts. Okay.
Yeah,
because
maybe other people have ideas as well. And, I guess the one thing about the administrative measures that's always difficult is because the data is so delayed in the portal, it's hard. So like for my CQMs, like, man, I'm running that, by like the 5th of the month, I'm running it. I know exactly where I am. I'm sending out lists of gaps in care, right? I'm got my front desk staff, get these kids in, get them scheduled for a flu shot, get these kids in, get them scheduled for, fill in the blank. And with the administrative measures, I think part of it feels like we're flying blind, and because the data is so delayed, and and by the time you get it, it's almost too late to try and improve your score, because it's not happening fast enough like some of the other ECQM measures. And so, while I appreciate that we can choose some of the administrative measures, I feel like we don't have as much control and as much ability to be aggressive about maximizing our score, because I never know where we are in real time. And I guess the other thing that I would say is, and I think this is true for most practices, is the RAs really have a lot of interaction with us, and like they know what we're doing. And so, going back to like structural measures, it's an opportunity for us to continue working on QI projects that continue to overall improve the quality of care and the quality of our processes. And so I think, especially for PEDS practices where it's, it's difficult to find a whole lot of ECQMs that we can report on, allowing like another structural measure or something, and recognizing that, like, man, I meet with RAs like at least once a month, and sometimes more often than that. And we're working hard on, CQI projects and quality care.
So you're welcome to reach out to me to provide us feedback. Very appreciate you raising the issue, and we are having conversations among the quality team about the whole issue of data refresh. And I think everybody on the call is very familiar with the speed that occurs. And I can just tell you from a clinical perspective, I'm pushing for more frequent refreshes, but that would require recognition by everybody that in some cases, it would be less mature data you'd be getting, but it'd be more frequent. And so I appreciate all the issues you raised, and you're welcome to reach out to me.
Nicole, is there something you wanted to add? Go for it.
Yeah, I just wanted to remind everybody that on the administrative measures, the measure specifications require us to give a 90-day run out period after the end of the period that we're reporting on. So we did build in the rolling 12-month reporting so that practices could see who's coming due. So if I got a report today, I could see who last had their well visit, October, November, December of 2021. I know that won't capture somebody newer, but at least it should hit most of the population. But we intentionally did that rolling 12 months so that practices could use that as a registry function kind of. So I'm not sure, Jill, if you guys are downloading the member level data from the DAP, but that could help to make it feel a little bit less flying blind. But we are required by the measure steward to give a 90-day run out period. And then by the time we report and get it out to DAP, we do that. We turn that around in about 6 weeks, which is fairly quick. It's that run out period that's pushing it out so far.
Yeah, and I mean, we're fortunate in that our attribution is probably around 4,000, but for practice, and even at 4,000, like downloading data takes a minute, and the larger your practice, the more time it takes.
All right. I just wanted to highlight a couple of questions that we received in the Q&A that were similar around points for measures, and just wanted to reiterate for the group that the methodology for calculating points, so the close the gap methodology and receiving points for reporting ECQM data, receiving partial points for measures is not changing. So thanks for those questions, but just wanted to make sure that that was communicated to you all as well. Let's take one more question and then keep moving to the rest of the slides we have for you here today. So Katrina, if you want to go ahead, you've got your hand raised so we can take your questions.
Hi, good morning, everybody. It's Katrina from Heartlight Family Clinic. So, I appreciate the fact that we're trying to narrow measures and make it simpler, but at the same time, I think Jill and the previous person mentioned that when you do that, it gives us less of choices. When I look at that, it's great that there's 50 measures to pick from. The problem is when I look at those 50 measures, and I compare it to what my EMR is capable of providing versus what you guys are capable of providing, I'm left with no choice. These are the ones I have to report on because they're the only ones that are reportable. And so, you know, when you narrow that and take points away, especially the structural, I'm down to, okay, I'm pretty sure we're not going to make the points. I'm pretty confident of that. So then everything we're doing seems like it's punitive, you know, because we can't meet the measures if we don't have enough options to choose from. Just to give you an example. So we always pick hemoglobin A1C. We're a primary care clinic, you know, and our hemoglobin A1Cs after COVID were dismal. You know, people weren't coming in. They were, you know, they were stress eating. A1Cs were high. The rest of them weren't coming in. It was terrible. So now we've got it back down to, we had it around 40% a few months ago. You know, the goal is 15%. And that goal of 15% just seems so unattainable because number one, about 15, sometimes 20% of our patients are seeing endocrinology because they've got type 1 diabetes. They're not even seeing us. So we're listing it as a diabetes in our diagnosis code because we're taking care of the other aspects of the diabetes, but we're not actually doing the A1Cs. They're doing that at endocrinology. We've got people who just won't come in. They're not willing or ready to make the lifestyle changes. We've reached out to these people 5, 6 times. They just won't come in. There's a segment of the population like that. So 15% is not attainable. We're currently down at 30%, and we hover between 30 and 40%, depending. And so it's impossible for us to make that 10% gain in order to get full points. And so now my hemoglobin A1C, which is one of my gold star, you know, measures that we work so hard on, I'm not going to get hardly any points for those. And now we're taking away structural measures. And now the depression screen, which we happen to do really good at, has got less points attached to it. It just seems like everything that was working for us is being taken away from us. So how are we supposed to meet the measure and get the 200 points to prevent us from getting a deduction? Because at some point, it doesn't make financial sense to continue to do this with it being punitive. Do you hear what I'm saying?
Thanks, Katrina, for sharing. Zoe or Nicole?
Yeah, I can try and Nicole can jump in if she wants to after. We do understand, and we're not trying to be the bad guys and limit measures and not let people succeed in the program. That's not our goal. Though we do know making changes is hard and all of that, but we do have, you know, for those you can report on, close the gap. So you are still able to earn partial points on measures, even if, you know, closing the gap by 10% is unattainable. So we do understand, and we are trying to stabilize the measure list, and the measures that we do choose for the APM are the ones that are the best that the department can report on. So there are more core measures for adults and pediatrics, but there's just not the data to support them. So I guess, Katrina, I'd be interested to know like what measures like you are able to report on in your EMR that are different from our list. So maybe we can have a follow-up conversation on that, because I have no idea what an EMR looks like from a provider point of view.
Thanks, Zoe. We've got one more hand raised. Let's take that, and then we'll keep moving to a few more slides. And we will have more time for questions at the end, don't worry. So Crystal Ryder, if you want to go ahead, we can unmute your line.
Yeah, thank you. So my question is, because of the reduction in the number of measures and the concerns posed, have you guys had any discussion about reducing down from 200 to have that the number of points needed reduced down to maybe combat some of these concerns that practices have? Because I definitely have my own concerns with this whenever we have 2 less measures, and then I have a newer EHR that I'm trying to even get baseline data out of. And so for me, I can't close the gap because I don't have baseline data. And so I'm having a real struggle when I think about that 200 points. I'm going to very likely not earn that 200 points and then have a reduction, and that concerns me.
Thanks, Crystal. Any thoughts, Zoe, Nicole, Dr. Walsh, on the point total? Otherwise, we can take that feedback back and keep moving. Zoe, did you want to share?
I think we can take it back for discussion. 200 points has been what the program has been. And so when you start changing all these different things, I feel like then we're just at a different baseline. So we're trying to keep things as similar as they've been year over year, but also trying to streamline, simplify, and get to a place where we're not making so many changes and people also feel like they can succeed. We will be walking through like our vision over the next few years in a couple slides, and Dr. Walsh will walk you through that. I think we'll probably leave it at that, and we can have any follow-up, and we'll take that back for discussion.
Great. Okay, Zoe, let's keep moving in the presentation. I know we've got a few more slides to get through, so back to you.
Thanks. So this will probably not be received maybe very well since everyone seems to have strong feelings about structural measures. So in addition to reducing the number of structural measures PCMP will report on, we are also proposing to remove the following 4 structural measures from selection, so that you will still be left with 7 structural measures to choose from. The first one we're proposing to remove is accepting new patients. This has been a topic of conversation at other stakeholder meetings. It's raised concerns with the RAIs and PCMPs. It's inaccurately and inconsistently capturing and reporting on this measure. So that is the reason we're proposing to take this one off of the list. Not that we don't want providers to continue to accept new Medicaid patients. It's just because they are open to accepting new patients the majority of the year, that doesn't really accurately reflect the number of new Medicaid patients that they are receiving or scheduling for appointments. We are also proposing to take off ED and hospital follow-up, lab and imaging tracking, and referral tracking. Some of the reason for this is they have been selected highly over the last 2 years, which suggests to the department that PCMPs already have these processes in place, and thus why we feel comfortable removing them from the list. I'm going to pause here for any questions.
Yeah, we have a poll for the group. So based on these 4 measures that Zoe just walked through here, we'd love to hear from you all if you have any concerns with specific measures. So there's a Zoom poll launched now. Let us know if you don't have any concerns or if you're thinking about concerns for specific measures. We'd love to hear from you here. And then please feel free, if you have a question, raise your hand or get at us in the Q&A. Okay, we have a couple hands raised. Let's start with Andrea.
Hi there, can you hear me?
Yes, we can.
Okay, so I just wanted to mention that obviously I share the same concerns that everyone else has expressed about, you know, reducing measures, points, but then also removing the structural measures. One thing to note is accepting new patients used to be worth, if I remember correctly, 50 points. So that's a big change, and something that, like, by adjusting those points makes a big difference to practices. And then in addition to that, Colorado Access, as our RAI, is actually still requiring us to accept an unlimited number of new patients. And so by removing this, it is sort of a moot point from a structural measure, and kind of going with the theme that other folks have expressed is just perpetuating sort of this feeling of not being able to succeed, making the program significantly harder and more challenging, and arguably pushing practices to either not participate in the program because it's not worth the lift from year to year, but also considering, right, doing the least amount minimum or the least amount possible to receive the minimum amount of points, or the number of points that would be needed to not suffer a fee-for-service rate reduction.
Thanks for sharing. We have one other hand raised. We can go to Sarah.
Yeah, so I really appreciate this. I'm not a PCMP, so this is just really helpful. I'm a telemedicine company that serves the Colorado Medicaid population statewide, and we are trying to support the PCPs to meet their measures, along with, just manage their populations that are maybe over attributed or just very hard to get access very quickly. And our issue is that we also get a lot of patients that aren't engaged in their healthcare and they can't get in. And so my concern for these first two are that if you stop measuring them, if they're going to be, first of all, the question is, are they going to be still reporting them? And are there going to still be, making sure that there's incentives to actually continue to do these things in a adequate amount of time? Because that's one of the hard parts for us, is getting them in or finding a place that's taking new patients. And we do a lot of the ED follow-up, so that patients don't have access to their care. So that's just the question that I have.
I can maybe jump in here a little bit, just kind of like on all of these overall. We're not trying to dissuade practices from having these things in place. We're not trying to take away all the structural measures so that practices don't already do these things, but we are just trying to move more towards clinical outcomes. So it is kind of a balancing act of like, how do we get practices to choose more clinical measures, because that's the direction we're going, and want to phase out these process measures, but also allowing practices to still have these things in place. So we just don't want them necessarily tied to the APM. Not that we don't want practices to have these things in place. We just feel that practices, most of them probably have a bunch of these things already in place. And that's why we're kind of trying to move away from some of these process measures that have been implemented and shift that focus more towards the clinical piece of the program.
Thanks, Zoe. Would love to hear from any other participants who had some concerns. It looks like accepting new patients and followed by the ED and hospital follow-up and referral tracking measures, that folks had some concerns with those. So would love to hear from you in the chat if you have specific concerns or if you have questions, to use the Q&A. We've got 2 hands raised, so let's go ahead and take those. And then I know we want to be sure to get to the vision for beyond 2023 before we close. So let's start with Elizabeth. You want to go ahead?
Sure. Yeah, I want to be cognizant of time, but I guess I think my sense from all the concerns here are that the structural measures are things that we can control, and the quality measures are going to reach an endpoint at some point. And so shifting the balance to quality is not necessarily going to help. But I guess mostly I want to ask about this endpoint. And so what I'm hearing from HCPF is that phasing out the structural measures, the purpose for that is because there's an expectation that practices will just reach a saturation point on structural measures and practices will just be great. They'll have all the infrastructure set up that the structural measures have incented, but I think that's not necessarily happening. And I think given all of the instabilities in the healthcare delivery system, with workforce, with tech data constantly shifting requirements from feds, locals, different payers, et cetera, the structural measures, I guess I would like to better understand the department's vision for the endpoint, you know, phasing out the structural measures. What is it that you're expecting to achieve? Like, what is the, at what point will the structural measures no longer be necessary?
Thanks, Elizabeth. And we've actually got a couple slides on the vision beyond 2023 to walk through in just a moment. So I think that that might be answered here imminently. But Zoe or Nicole, Dr. Walsh, do you have any other?
I think we should
comments
talk
before
to
we
it
go
when
on?
we talk to the vision slide, the potential, you know, the future direction slides.
Sure. Okay, great. Thanks, Elizabeth, for sharing. And we've got one more hand raised. We want to go to Claire.
Hello, you guys can hear me?
We can.
Okay, great. Thank you. So we're actually new to APM. We're practice we opened about 3 years ago, but we have a lot of Medicaid patients and we are happy to accept them. As I'm sure everyone knows, which is just something I want to bring up that, you know, might be considered when thinking about reevaluating measures is, so we're a part of another program that we do basically PMPM for our commercial payers that we take. And I was one of them who said that I think accepting new Medicaid patients and hospital follow-ups, I think those should stay. And the reason for that is because, you know, we're never going to, I feel like, find 100% way to make sure that we're following up with hospital visits. You know, we always have to be on those. And some patients call us back, you know, some come in, some don't. I feel like that should stay a measure forever, this, in my opinion, because it is important to get, as a primary care provider, which I am, I think it's really important to get our patients in after hospital visits. And I have my medical assistants call not only for the ones that are inpatient stays that we get credit for, but I have my MAs call for transition of care calls, even for ER visits, even if it was just for a pregnancy, you know, just because we are primary care providers and we want to care for our patients. And, you know, it's great the rewards that we get out of these programs, and I truly appreciate it. You know, but I feel like listening to a little bit more to when providers and caseworkers and whoever's on this call, you know, when they say, because I saw a lot of people put, you know, it would be great to keep accepting new Medicaid patients and it would be great to keep the hospital follow-ups to count. So that was the hospital follow-up thing I wanted to say. It's always going to be important, I feel like. And not only for providers, but also to get the MAs to call. You know, we have to, obviously, I think we all know, we always have to give incentives a lot of times for things to happen. And that's just how we are as humans. And I think to keep hospital visits, again, is important. And then secondly, getting credit for accepting new Medicaid patients, I also think is important because, number one, we know that when Medicaid patients no-show, we cannot bill them a no-show fee. In my practice, I'm sure it's happening in others, but I'll just speak to mine. We have, I mean, at least 10 patients a day, maybe more. And we also have mental health counselors who see them that are not showing up to their visits. And we can't do anything about it, except we made a rule after 3 no-shows, my manager, Courtney, will call them and say, hey, you know, it's disrupting and it's taking other slots away from to see you if you keep no showing. But then on the other hand, Medicaid has a lot of rules. You cannot deny service, you know, and there are certain circumstances where you can if they're non-compliant, et cetera. But sorry, all of this just to say that Medicaid has a lot more rules than commercial. And at least with commercial, we can still, you know, I just want to say as an owner also, and as a provider, it's really hard to make sure we're making payroll and make sure we're able to give our staff the money they deserve for the hard work that they do when we're constantly having Medicaid patients no show and there's nothing we can do about it. In conclusion, that's why I feel like accepting new Medicaid patients should continue to be, you know, counted. Sorry if I talked, but I have a lot to.
Thank you, Claire, for your feedback. All right, let's keep moving. I know I'm going to pass it now to Dr. Walsh to kind of introduce the vision for the next 3 years, and then hopefully we'll still have time for a few questions and comments at the end. So Dr. Walsh, over to you.
Yeah, if you could move on to the next slide, please. So I'm going to briefly talk about what some I'll say policy decisions that we're considering in the future. And I want to stress the fact that none of these are decided, but we're trying to be transparent about what we are trying to accomplish with the program, I'll say in 2024, 2025. And obviously would have to go through a stakeholder process for them to occur just like this one. And the other point I want to emphasize before I get into it is this is an APM program, and it was designed to be a value-based payment program. It was introduced, an objective of this is to introduce accountability for what was initially at the time a 4% increase that was legislatively approved, tied to an APM program. And so we are trying to operate an APM program, and it's called APM 1 because this was the first, and we're continuing at the department to work on APM programs. So whatever we do with this program, we'll have to take that into consideration in terms of how they evolve. But the original plan, and our plan does continue to be to eventually phase out structural measures and credit for PCM recognition. And the thought process was, when the program was developed, was that these would be initial actions. We recognize practices are forming all the time and dissolving. However, it was not designed to be ultimately based in the long term on structural measures, with the belief that whether or not you incentivize as part of this program the implementation of a structural measure, it shouldn't be necessary to continue to incent it once those processes are developed. We are trying to shift to a more outcome-based measure set in terms of how we measure value. We do anticipate this all to stabilize in approximately the 2025 timeframe, and we are interested very much transitioning to incentives based on Health First Colorado member performance when technically feasible. And what I mean by that is that while we do have some administrative measures in place that do measure, I'll say, the metrics with regard to Colorado Medicaid measures, the ECQMs we currently have in place do not do that. They measure the whole panel. And the reason why I say technically feasible is because you realize that it's not feasible this year. But when it does become feasible, we want this value-based purchasing program to be based on, I'll say, quality and metric performance with regard to Medicaid members. Next slide, if you could. So this, again, is not decided, but demonstrates those I'll say principles applied. It shows what we've talked about in 2023, but of examples of what may happen in the future. And so the middle column demonstrates the fact that for PCMPs, we would potentially decrease structural measures next year. For FQs, you can see the credit for PCMH potentially might decrease, for instance. And you can see in 2025, potentially there could be no structural measures. There could be fewer measures overall. There could be no PCMH credit. But the conceptual framework here is that while we think what the structural measures were initially developed for and what PCMH credit was originally designed for was very important, and the need for them don't go away, but the objective was not to have them be the central aspect of the program in the long haul. And so finally, we are, what this slide doesn't say is we are trying to move towards core measures when possible. And we are also, as part of, I'll say, the 2023 or 2024 and beyond, is we're going to try to the extent we can align with other programs that may develop in the state. So with that, Nina, I'm going to hand it back to you. And if you have time for questions, I'll answer, but otherwise, that's all I have.
Thanks, Dr. Walsh. All right, so we have reached the end of the content that the department wanted to share with you all today. So we'll open up the floor for final questions about anything Dr. Walsh just talked about, anything that we discussed today that you didn't get to ask about or comment on. We have a few more moments for some questions. So we are ready for them. There's one question in the Q&A. How does Colorado's APM program align with APM programs in other states? And are decisions based off of what other states are doing in their programs? I know that you all have looked at alignment across other states and programs. Dr. Walsh, Nicole, Zoe, if somebody wants to chime in. Dr. Walsh, go for it.
Well, and Zoe may want to as well. We are looking very closely at APM programs in other states, and I'll say that this program really preceded a number of other programs. And I guess what I'd say is it's different in terms of how it was designed, and it's innovative. A lot of other states have gone, it's difficult to compare to other states entirely because to some extent they have a different overall Medicaid structural model with regard to being fee-for-service versus managed care, for instance. But standing back from that, a number of states have focused on I'll say an episode, chronic disease, or other type of episode type model within their Medicaid program. And all of that is being very closely looked at from a department perspective in terms of what the department may or may not do in the future. So there are other states that have APM models, but frankly, this is different than those because it's a different innovative approach. And so I don't know if you want to add anything else.
I think you said it pretty well, Dr. Walsh, but I guess I will just add in that, you know, by us reporting on the CMS core measures, it's easier to compare us against other states when looking at the outcomes of those measures. It's comparing apples to apples versus, you know, kind of our structural measures, which are homegrown measures. Those are really hard to compare to other states. So just shifting the focus to core measures, we're able to see how well Colorado is doing compared to other states when it comes to those clinical outcome measures.
I'm going to move us to the last slide just in case people need to jump because I want to make sure that this information is up for folks, but we do have one more hand raised. So Claire, if you'd like to share a brief comment with us before we close. Go for it.
Yeah, I actually just wanted to kind of hear what maybe other practices or even you guys feel about what I said. When I talked about, you know, thinking that hospital visit follow-ups should be counted, and same with accepting new Medicaids, because like I said, I don't think those things are ever going to be fully satisfied, and it also affects the practice when, you know, the issues that we have as a practice when Medicaid patients no-show or things like that. So also would be nice to consider those things that affect practices when considering your measures. I just wanted to hear what other either practices or what you guys kind of felt about that.
I can jump in, Nina. I'm probably not going to be able to directly answer your question just because I think the department needs to regroup on evaluating taking those off the table. We do understand, you know, if Medicaid patients no show, it's a real issue for practices, and not that we disagree with you. We know it's an issue, but it's just a bit outside the scope of the APM, but we're happy to circle back on it. Feel free to send an email to the focus groups. I'm happy to touch base with you personally on those, and then we will be following up with some of our final recommendations regarding taking those certain structural measures off the table, as well as the other program requirements that we talked about today. Are there any more questions, Nina?
Well, I wanted to see, I know we're over time. Zoe, Dr. Walsh, Nicole, do you have another couple minutes to hang on? We do have another hand raised. Do we need to wrap it up, or can we take a couple more questions?
I can hang on, but I'll leave that to Zoe to decide what we do.
I'm able to stay on, but if anyone else from the department needs to drop, feel free to do so.
All right, we've got one more hand raised. Crystal, if you want to share with us, go for it.
Oh, I thought I lowered my hand. I was just going to say I agree with Claire and I appreciate her provider owner perspective. It is difficult with the number of Medicaid clients that do no show, even with all of our efforts, it is really difficult. So I just wanted to provide agreement to what she had stated, so.
Thank you, Crystal. And there's one outstanding question in the Q&A from Nate. As healthcare evolves and changes, there will be a need for new and refined structures to be put in place. Anticipate some huge leaps in technology will hit in the coming years. Any thoughts of incentivizing those new structures through APM as they come up? Any thoughts on that question? And I think that'll be the last one. You can close. Dr. Walsh, go for it.
Well, again, Zoe could answer this as well. We are considering many things. And so one of the things that we're talking about this program because this isn't a program that's existing. We're attempting to keep it functioning as we carefully consider our future directions. And so hence the term APM 1. So many things are being considered in how we approach models in the future. But there's a large contract that the legislature gave us money for continuing development around APM programs and value-based purchasing programs for this current fiscal year. And that contract is in the process of in procurement for state regulation. And that will lead to, I'll say, the development of, the follow-on to this program. And so there are many things being considered. I think it was a insightful question on how other states do things. I think they do it in very different ways between different states, and we're looking at all of those. So, and you notice how we said things will stabilize in 2025. All things are being considered. Yes, it's a key effort on the part of the department. It's vastly complicated to do this in a way that's, I'll say, coherent and really does reward value. And all things are being considered. So major effort underway at the department. And those future programs, we're trying to not intermix that conversation with this program because I think all of you are living through even the complexity of making, I'll say, what I think tweaks is an understatement, but any changes we make to this program, have a ripple effect in all your practices. And so we're trying to keep it going in the direction we're trying to go, which is core measures in terms of actually how we measure quality for a variety of reasons. At the same time, we're trying not to be too disruptive until we know what, I'll say, our next steps are in the follow-on program. It's a great question.
All right, thanks, Dr. Walsh. So we'll just go ahead and close up here. A reminder to send any written feedback to focusgroups@coloradohealthinstitute.org. We'll continue to take feedback through next Wednesday. So thank you all for your feedback today. And I'll pass it to Zoe to close us out with a couple final remarks.
Thanks, everyone. So I just want to thank everyone so much for participating and partnering with the department as we work through these changes for the APM program. We really do value your feedback and input and just want to continue to hear from you. So please reach out to us. We will let you all know mid to end of November on any outstanding items that have resulted from today's discussion, as well as decisions made by the department. And then we will let you know as soon as possible on any measure changes from CMS and that the department is considering. The department is also playing with the idea of having some quarterly forums with a much smaller group of our super involved stakeholders, just to stay more in touch consistently and work through some of these program changes as they come up, as opposed to just all at once near the end of the year. So we will also be following up with more information on those. And we will lastly open up measure selection January 1st, and it will run through January 31st. But we will be in touch much more with all of that and what all that entails in the coming months. So thank you, everyone, and I hope everyone has a great rest of their week.
Thanks, Zoe. And I echo her thanks to you all for your participation over the last few months. Thanks for being with us and for hanging with us for a few extra minutes today. Take care, and we hope to hear from you soon. Thanks.